Good morning, and welcome to today's webinar on creating sustainable HIV program funding locally and abroad. In response to the HIV epidemic, governments and international philanthropies have supported the implementation of effective HIV prevention and treatment programs around the world, contributing to a 40% drop in new HIV infections since 1997, according to UNAIDS. The U.S. government, through PEPFAR and other programs, is an important contributor to the AIDS response, but its funding has decreased in recent years. What happens when initial program funding comes to an end? Local communities and national programs may scramble to secure reliable non-grant funding sources to sustain valuable programs. Abt Associates works closely with those communities and countries to support their HIV financing transitions. A little bit of housekeeping before we begin today's webinar. Today we will hear two 15-minute presentations about sustaining HIV program funding. After each presentation, we will allow 10 minutes for questions. Everyone's line has been muted, so please enter your questions using the Q&A box on the top right corner of your screen. You can enter your questions at any time during the presentation. You do not have to wait until the speakers finish. We will be monitoring the Q&A throughout the webinar. Now let me briefly introduce myself and our speakers. I'm Kathy Whitgert, a Senior Associate at Abt Associates, and I'll be moderating today's webinar. I'm joined by two of Abt's Principal Associates who will be sharing their expertise with all of us today. Jane Fox is a health services researcher with over 25 years of experience in providing TA and evaluation services. She has worked at the local and state level to increase access to quality care for people living with HIV. Most recently, she directed evaluations of multiple special projects of national significance to improve HIV and other healthcare services for people living with HIV. Ms. Fox has a bachelor's degree in Human Development and Family Studies from the University of Nevada, Reno, and an MPH in Health Education from Emory University, Rollins School of Public Health. Lisa Tarantino is the Portfolio Manager of USAID's Sustainable Financing for HIV project in Vietnam. In addition to this role, Ms. Tarantino is the Director for Transition and Sustainability and the Regional Program Manager for the USAID Advancing Sustainability Through Local Health Systems project. She has more than 20 years of experience designing, managing, and evaluating complex global health and development programs, including in countries of the Caribbean, Eastern Europe, Southeast Asia, and East Africa. Her professional experience in over 20 countries has specialized in development finance, sustainable approaches, and transition from donor support. She is an advisor to Johns Hopkins School of Advanced International Studies International Development Program. Ms. Tarantino has a master's in international affairs from Columbia University School of International and Public Affairs and speaks Russian. Before I turn it over to our speakers, I want to remind everyone that today's webinar is being recorded. Now I'm going to turn the presentation over to Jane to share examples from the special projects of national significance in 3 U.S. cities. Jane?
Thanks, Kathy. The special projects of national significance are funded projects through the Health Services and Resources Administration, HIV/AIDS Bureau, and they're designed to create innovative models of HIV care and treatment and provide time-limited funding. These innovative approaches to sustaining financing in these 3 local HIV programs, initially funded with federal grants, include an oral health program, a mobile medical team caring for persons experiencing homelessness, and a care coordination model serving individuals leaving jail. Each program developed a sustainable funding stream to continue its program using an approach tailored to their local community. It's not letting me. Thank you. The first model is AIDS Care Group, which is located in Chester, Pennsylvania. They were funded through a SPINS initiative in 2006. It was a 5-year initiative that funded 15 sites across the United States to design innovative models to increase access to oral health care for persons with HIV. They also funded an evaluation and technical assistance center to conduct a multi-site evaluation, and provide technical assistance both on evaluation and oral health content to the 15 sites. Of the 15 sites, the models typically fell into three main categories. One category was mobile oral health care, where sites purchased a mobile health van. Dental case management, where sites incorporated a case management model, but in the dental clinic. And the third model was building new dental clinics. Abt Care Group did build a new dental clinic. They started with portable equipment that they took to local community agencies to conduct oral health exams to determine what the true need was in their community. They then built an oral health clinic at their HIV clinic site. So 5 years of funding goes quick. All of the SPINS projects that I've worked on, we start talking about sustainability on day one. Thinking about how to sustain a project in the last year of funding is a huge setup to fail. So sustainability planning takes time. So what Abt Care Group did is about midway through their project, they had built their clinic, oral health center, and they found through a community assessment that there was a high need for oral health care in their community and very few oral health providers to meet the needs of the community members. So to sustain their program post-SPINS funding, they expanded their services to the general population and expanded their ability to accept both insurance and Medicaid. They then used the revenue that they collected to support their original work to provide low-cost oral health care for persons with HIV. The second model is the Homeless Health Outreach Mobile Engagement model funded at San Francisco Department of Health. This SPINS initiative ran from 2012 to 2017, and the overall initiative was designed to build a medical home for persons with HIV who were homeless or unstably housed. 12 sites were funded, as well as an evaluation and technical assistance center, and the gist of what the sites were asked to do was to design models of care to provide integrated health and housing assistance to this population of homeless or unstably housed persons with HIV. The Home Project in San Francisco committed to delivering low-barrier, client-centered medical, psychiatric, and addiction treatment services outside the four walls of an HIV clinic. They also offered medication and adherence support to achieve viral suppression, as well as psychiatric stability. They increased access to emergency stabilization, as well as supportive housing, and they decreased emergency department and hospital service utilization. They were a mobile, multidisciplinary team designed to engage and retain some of the hardest and severely impacted persons living with HIV and AIDS experiencing homelessness in the San Francisco area. Home truly filled a gap in the San Francisco service model, working with clients who were identified as high users of multiple systems. They were able to identify a cohort of clients who accessed multiple social service programs as well as multiple emergency departments around the city and county of San Francisco. These clients were the most difficult to engage in care. Many had HIV for several years, had been homeless or unstably housed for many years, and had comorbidities of both mental health disorder and substance use disorder. And they had found that they had multiple failed attempts to access services, which made them very reluctant to continue accessing services in the city and county of San Francisco. So to maintain this project as well as work towards sustainability, the key partners that this project worked with were the San Francisco City Jail, the Homeless Outreach Team, the Tom Waddell Medical Clinic, and many other local social services relied on Home to serve this client population. Partners in other city county agencies were unable to successfully serve this population in the past. So the outcomes, to sustain this program post-funding, Home was able to lobby the city and county of San Francisco, and at the same time, many of their key partner agencies also joined the lobbying efforts. What it yielded was the Department of Health did allocate some of their existing Ryan White funding to support the continuation of Home. And now, 2 years beyond Home, it is still running, and the city and county are considering to expand this Home model to persons without an HIV diagnosis. The last project I'm going to talk about is Transitional Care Coordination. So this was a SPINS initiative that was funded from 2015, and it's wrapping up in 2020. This initiative is not like the others that I've discussed or that have happened in the past. This one was actually designed to study the replication of successful models from past SPINS initiatives. It was focused on 4 different interventions. One was integration of buprenorphine into HIV care settings. The next was an enhanced peer navigation model for HIV-positive women of color. There was also a peer linkage and re-engagement of HIV-positive women of color into care. And the last one is transitional care coordination. Each one of these models was replicated in 3 Ryan White settings. The transitional care coordination model was designed to identify persons with HIV in jail settings, either through on-site testing or through self-disclosure of HIV status. And this was replicated in 3 U.S. locations: in Raleigh, North Carolina, through a collaborative project that involved both UNC, University of North Carolina, and Wake County Social Services; Camden, New Jersey, which was funded to Cooper Health System; and the last one was in Las Vegas, funded to the Southern Nevada Health District. So going into this replication mode, all 3 sites had solid support and backing from leadership at both the health department or clinic level and the jail leadership. They then built a wide supportive network of community partners, and truly they were the only programs in their community doing this work. It ended up that the TCC group served as a community coordinating effort. They held key partnership meetings quarterly, which started out small but really blossomed over time, bringing in other community agencies. And they found that this model could be expanded to serve other populations. So to sustain the program post-SPINS, at all 3 of the sites, the TCC leadership and key partner agencies requested the continuation of the program using other Ryan White funds. More importantly, and I think somewhat exciting, was that 2 of the sites have been able to expand this model to include clients with hepatitis C, using pharmaceutical funds and county hepatitis C funding. And one site, Las Vegas, is considering to expand the program to include clients without HIV who are identified as having substance use disorder upon entry into jail, and using this model to link them solidly post-incarceration into substance use treatment outside of jail. So I think that one of the most important things that we have seen over the course of these 3 initiatives that seem to support success in sustainable financing is truly community relationships. Each one of these projects were able to provide a service to their community that was not available before, but also to bring the community in to create a network of services, not only for the populations they serve, but for the larger good of those community agencies. And truly, the cross-agency partnerships have been key, not only in building models that include multiple agencies to help clients get the services that they need, but also to to promote funding opportunities between the agencies to support the partnerships, as well as you've seen, lobbying opportunities within their own communities by other agencies to support the continuation of these programs in the agencies and in the communities that they work in. So I'm happy to take some questions. If you would like to ask a question, please type it into the chat box.
Thanks so much, Jane. Those are really inspiring examples to hear about. Maybe one question to start us off. The new U.S. Ending the HIV Epidemic initiative is getting talked about a lot. So how do initiatives like these SPINS models support that new initiative?
Absolutely. Thanks for that question. So as we know, in February 2019, President Trump unveiled a new initiative to end the HIV epidemic by 2030. The plan right now talks a lot about we know what works. We know it works in reaching out to identify clients who need services. We know it works in linking clients to services as well as keeping them engaged in care. And these evidence-based models that also now have evidence around sustainability are the type of models that are key in moving towards ending the HIV epidemic. Other questions?
If people have questions, go ahead and keep those coming into the chat box. I wonder, Jane, if you can talk a little bit about some of the other work that Abt Associates is doing to support ending HIV.
Certainly. So Abt Associates is engaged in about 8, maybe 10 different HIV specific contracts. One in particular is we are working with 3 clinics in the Massachusetts area under the Ryan White Part D, which is a set-aside amount of money to serve women and families impacted by HIV. Those 3 clinics are working to implement a modification of a past intervention that has been, deemed an evidence-informed intervention through the SPINS initiatives. To identify women who have fallen out of HIV care or who are loosely linked. And when we say loosely linked, we're thinking about comorbidities of homelessness or unstable housing, substance use disorder, mental health disorders. This is a curriculum that has been designed with the 3 clinics. And the 3 clinics each have a care coordinator and an HIV positive peer who identify clients who meet those criteria, contact them, and then work with them over the course of a year to provide 6 educational sessions around HIV, knowing what your lab tests mean, how to interact with your care team, how to think about ways to disclose to people in your life, your status, and adherence. And then maintaining contact with them after they have completed the 6 sessions for 6 months to make sure that they are remaining engaged in their care and attending their appointments. We are using an approach really to look at how this is implemented, and we use real-time opportunities to update the model with the teams. So we meet on a regular basis, typically monthly over the phone and quarterly in person, to talk about moments where we can be doing some of this better, to talk about where there are pieces of the curriculum that maybe no longer are as relevant as they have been in the past. An example being the coordinators and peers are finding that they need to talk less and less about side effects because that doesn't seem to be such an issue with the new medications. And so we're talking about, okay, if we take out side effects, are there other pieces that we should be boosting to help people stay engaged? So it's a really nice real-time project that we are working on with these 3 clinics.
Thanks so much for sharing that example, Jane.
Sure.
If people have more questions for Jane, please type them into the Q&A box on the bottom right side of your screen. In the meantime, we're going to move on to our second presentation. So we'll let Lisa talk about sustainable financing in Vietnam. Obviously, sustainable financing is not a challenge just here in the United States, but around the whole world. So we'll turn it over to Lisa Tarantino.
Thank you, Kathy. So I'm going to talk a bit about a program that Abt Associates is supporting in Vietnam in support of the government's efforts to sustainably finance their response. Abt has been working there for over 10 years, but what I'll be focusing on today is our efforts to support the government just in the last couple of years. The USAID Sustainable Financing for HIV Activity supports the government in mobilizing and increasing local financing for its HIV response as the whole response is transitioning away from donor financing to domestic financing. So first, a bit about Vietnam. It's an extremely dynamic country that has been experiencing rapid economic growth in the last 15 years, 20 years. And with that has also come demographic, social, and other changes. The country's population is growing substantially and has risen to 97,000 people, most of whom are under 35. Poverty rates have also dropped. So average incomes are increasing, public services are expanding, and much of this has been driven by foreign direct investment, which also brings its own cultural changes. So the epidemic, the HIV epidemic in Vietnam is concentrated on some key populations. At the national level, the prevalence is less than 1%, and yet when you drill down to populations such as men who have sex with men, people who inject drugs, the prevalence is over 10%, and similarly with commercial sex workers, it's nearly 4%. The government of Vietnam and development partners together have made great progress in expanding access to testing and treatment. The rate of new infections has declined from 26,000 in 2003 to 5,700 in 2018. And all of this, during the course of this time, Vietnam has transitioned from a low-income country to a lower middle-income country. So what is the challenge? As I said, as the response to HIV has grown and become more comprehensive, for example, the number of ARV patients increased from 39,000 in 2009 to 139,000 in 2019. At the same time, development partner funding has been declining since 2010. In 2015, the government of Vietnam began transitioning away from development partner support. And this support traditionally had been in areas such as ARV procurement, technical and management support, prevention and key population outreach. So those are some of the areas where the government was particularly concerned about financing and how to manage, and all of this at the same time in the context of implementing a treat-all approach, which entails
every person who is identified as being positive begins treatment right away. And so there is a strong emphasis also on adherence, which can be a challenge with some of these key populations. So one of the major ways that the government has been seeking to address this challenge is with their social health insurance scheme. The World Health Organization defines social health insurance as a form of financing and managing health care based on risk pooling. Social health insurance pools the health risks of people on one hand and contributions of individuals, households, enterprise, and the government on the other. And pooled health insurance allows for vulnerable populations to access care regardless of income levels or employment status. Some of the challenges related to the social health insurance scheme expanding to cover HIV services, however, were policy and also financial. For example, the social health insurance scheme and the state budget have been running deficits year on year for the last 3 to 5 years. On the policy side, preventative services are not covered by social health insurance according to policy. Some other challenges include, on the administrative side, the ARV procurement had been disjointed with development partners doing some of their own procurement, the government doing its own, and so that was something that they were seeking to address in order to potentially achieve efficiencies. So the USAID Sustainable Financing for HIV program supports the government by supporting their efforts to mobilize and increase domestic financing and to ensure financial protection for people living with HIV. And by doing that, we mean reducing potential out-of-pocket expenses and ensuring that they are financially able to access services. I should also say, as part of their efforts, they have integrated provincial HIV control centers into provincial centers for disease control. However, these are still outpatient clinics that are separate from the public health clinics that are around the country. We're supporting the government's efforts to increase coverage under the social health insurance scheme for people with HIV by facilitating the integration of these outpatient clinics into the health insurance scheme and building their capacity to accept social health insurance and strengthening the government's capacity to coordinate and communicate with those health offices at the provincial level to help them to implement these kinds of changes. We're also putting a great amount of effort into helping the government understand what is involved in expanding their financing to different types of services. That is, looking at the cost effectiveness of different preventative services that they're not yet now funding. And helping them to understand what might be the budget or the social health insurance financing burden related to taking on some of these services that have been traditionally financed, primarily with development partner funding. And then lastly, by centralizing the ARV procurement, the government is seeking to realize some efficiencies. However, there are some logistic challenges involved with that, and by doing this kind of centralized procurement while also changing the way ARVs are being financed, the government is seeking to understand how this is all working, and are the drugs getting to where they need to be? Are they being paid for out of pocket or through the channels that they're hoping they're paid for, which is the social health insurance and local budgets for some subsidies. And so we're helping to implement information systems that can help them with those efforts. So the project just started at the end of September 2018. At the beginning of the project, not all of the outpatient clinics had been integrated into the social health insurance scheme. And by integrated, we mean that they had the processes, the documentation, the ability to be linked to the social health insurance scheme. And not only were they not linked, most of them were not accepting the social health insurance card and actually being reimbursed by the social health insurance scheme. So there's the difference. We're helping to bridge the gap between policy and what's written on paper and clinics being approved to do certain things and them actually doing it and the patients feeling that benefit. So in this slide, you can see the 430 outpatient clinics. The light blue is those that have been fully integrated, at least procedurally, into the social health insurance scheme. And the orange bar, which is the one we're particularly proud of, shows how many nationwide are accepting social health insurance and allowing patients to be, and being reimbursed and allowing patients to use that as a financing option. And we can go on to the next slide, but just, we're working at the provincial level, but there's a lot going on at the national level as well, with a very strong national AIDS program housed in the Ministry of Health, and a really competent and emerging in competency even more social health insurance scheme. And these two institutions and others are working together. Those procedures and the way that they're communicating is still really evolving, and it's complicated by the communication levels between the national and provincial in this decentralized health system. So we've been working, VAC is the Vietnam AIDS Commission housed in the Ministry of Health. We've been working with them on, at the national level, creating these financial guidelines for subsidy implementation, and that is the patients, when they use their social health insurance, that it covers the majority of the cost of the services and the ARVs, but there is a small out-of-pocket payment that's expected, and what we're working with is how to minimize those out-of-pocket payments with some subsidies, and working intensively in 5 provinces that are PEPFAR priority provinces. We're providing data on, as I mentioned, and also facilitating as a bit of a neutral broker situations and workshops where technical meetings can be held with national agencies and stakeholders to discuss how to revise the social health insurance law to make sure that preventive services are included, to do some rigorous analysis on which preventative services should be included and how that's all going to work. And we are pleased to say that with the new law, there should be some services included that will allow expansion to cover. And this is an example of how our work is generating data that helps the national level manage the implementation of expanding social health insurance to cover ARVs. And I'll show on the y-axis, this is the amount of ARV co-payments that are being made and being subsidized at the clinic level. And on the x-axis, you'll see the amount of SHI contributions that are being made in those particular provinces. And each little ball is a province, and the size of the ball, and I can't tell you the scale, but it indicates the size, the number of PL-HIV, people with HIV. So you see Ho Chi Minh City has the largest number, and thus they're receiving the largest amount of contributions and the greatest amount of ARV copayments. What this graph tells you also is those two dark blue balls at the end are two provinces where they have a very sizable number of people with HIV, but the government was seeing through this data that the ARV copayments were not comparable to the number of people in those provinces. And through further investigation and going to the provinces to understand better what was happening, we saw that because they didn't know well enough how to administer the social health insurance scheme, the clinics were reducing the amount of ARV that they were distributing per visit for patients in order to keep each visit at a lower cost. And the lower the cost, if it's below a certain threshold, they don't need to accept a copayment, and that was their workaround. And that was a flag for us to help support their capacity to implement the scheme. So what are some outcomes? Vietnamese domestic funding, and I will say that our project was just a small contributor to making this happen, but the domestic funding for HIV has gone from a third of the overall program cost to over half in 2019 so far. The percentage of people living with HIV that are enrolled in the social health insurance has grown to 90%. And ARV copayments and premiums for those of lower income, that are particularly vulnerable, are being subsidized with local provincial budgets providing the subsidy. In some cases, development partners are providing subsidies as part of their transition out of support. And the outpatient clinics have been nearly 99% of them have been integrated into social health insurance scheme, and ARV procurement is centralized. Those are our outcomes in the last year, built on 10 years of earlier efforts as well. So, any questions?
Thanks so much, Lisa. That was a really interesting presentation there. Can you talk a little bit first about maybe some of the other innovative financing solutions that Vietnam has explored?
Yeah, they went through a review of what are possible ways that they can expand financing for their existing services and to expand to preventive services. And they looked at earmarking state budget funds for HIV at the central and local levels. They looked at expanding, they are currently exploring expanding social health insurance coverage to treatment, not just treatment and screening, but personal preventative services like PrEP. They have explored an HIV trust fund as a mechanism for pooling resources from both public and private sources for prioritized allocation of HIV services. Social contracting, which is a way of the government contracting out usually nonprofits or NGOs to provide social services, and that there's a pilot ongoing for that. And I'm going to pause for a second on social contracting as being particularly interesting because it can engage organizations that can reach out to these key populations which are often a bit marginalized and may face stigma, and these NGOs can help broker the connection between the health system and these groups that are a bit hard to find sometimes. They're looking at mobilizing private funding sources, which would be nice, but there's not high expectations for huge percentages of the response being funded in that way. User fees, and also, lastly, by mobilizing financing by improving efficiency, basically doing more with less. And there are a lot of efforts going towards that strategy as well.
Thank you. There's a question here in the chat box that I think applies to both of our speakers. And so the listener wanted to know about how the stigma associated with AIDS impacts efforts like this to sustain or diversify HIV funding. So maybe, Jane, can you address that a little bit from your perspective, and then we'll ask Lisa to talk about that as well?
Sure, absolutely. I think as far as diversifying funding and sustainability, the stigma around HIV is not as much as an issue as the stigma that we see around homelessness, substance use disorder, mental health disorder. So certainly when you put all four together, it's like the quadruple whammy of stigma that clients have to deal with on a daily basis in attempting to access services. So I think on the client level, absolutely, stigma is still real. That's part of why in the model that I described as an example, we do have included as part of the curriculum a session on disclosure and helping people to think about who you can talk to in your life and who you can disclose to and who you can't. But truly, I think the bigger issue is around adding the multiple layers of stigma for clients around all of their comorbidities of behavioral health issues as well as housing issues.
Thanks, Jane. It's important to keep in mind that there can be these overlapping layers of stigma. So Lisa, what about in Vietnam? What do you see there?
Yeah, stigma in a place like Vietnam, and this is the case in a number of other countries where we work around the world, is a substantial barrier based on who these key populations are. So in Vietnam, it's intravenous drug users, men who have sex with men, and commercial sex workers. So, socially, they're relatively stigmatized groups, and some of the preventive services that are appropriate to these groups are not, for example, the prevention of transmission among drug users, opioid substitution therapy, and needle and syringe programs are not the most attractive ways that local provincial governments want to prioritize their spending, for example, when they're also faced with significant burdens around maternal and child health care and chronic disease, et cetera. So there's a bit of a sales job involved in showing the importance and how doing preventive services for these groups not only makes it a healthier society, but it can prevent the growth of the disease and the resurgence of the disease. It also impacts what services development partners fund, and that impacts the whole program as well. Yeah.
Thank you. So we have a question here about the government funding for program cost at 50% already, which is really good. Mm-hmm. And the listener wanted to know if there's a target in the future to increase this percentage, and kind of how do we think we might, or how does the government of Vietnam think we might get there?
That's a good question. Frankly, I don't know if there is a particular number target. Probably the target is 100%, because development partners, as the income levels rise and globally, funding for HIV is shifting away from middle-income country toward middle-income countries that have a pretty good handle on the response towards those with higher numbers of people with HIV and potentially, lower amounts of resources to devote to the disease. So I think that is the ultimate goal. I'm sure there are some development partners work with the government to put in place numbers that are quite clear, and probably the Global Funds grants have some agreement in terms of how the speed in which the government support for the funding should be increased.
Excellent. Thank you. We have one more sort of technical question. So if this is beyond what you were prepared to speak about today, just let me know. But there's some interest in knowing about the challenges in establishing accurate costing for the government side of services, and just how that relationship gets managed, and if there are tools that can be used to help set those kinds of costs or establish rates for some of these services.
Well, I can speak from experience in what we have done in other countries, and what I understand is also being done in Vietnam. Because some of the services, or many of the services, are being offered through development partners, and these development partners will have a home office in the United States or another country. There are some costs involved that would not be applicable to government offering the services. So in those cases, those costs would not be included in the costing, and they would look at, what is at the unit service cost in Vietnam, and people offering these services are Vietnamese in the country, and local costs are involved there. The government does have a very high capacity to do a lot of their own economic analysis as well, and they're currently in the process of doing a national health accounts estimation, which will give them a lot of really good information on how much is being spent now for the entire health sector, but it will be broken down also in terms of HIV and what development partners are funding, what the government is funding, what out-of-pocket payments are being made, and that should inform also their approach for future budgeting and understanding of the expenses involved in the overall HIV response.
Okay, great. Thanks so much. All right. I want to thank everyone for joining today's webinar, and a special thank you to both of our speakers. Everyone who registered for the webinar will get a link to the recording later this week. We appreciate your participation today, and we look forward to welcoming you back to future Abt Associates events. Thank you.